Good morning, everybody. It looks that nailing is not very popular among the audience here. And let me just show you something about it. We may add a new concept to your practice. We are going to talk about the intramedullary nailing of distal femoral fractures. And among our lecture, we are going to talk about the indications of the medullary nailing and whether to do it retrograde or antegrade. We are going to have some comparison with plate, and then we'll talk about cons and pros of this. Now, before we start, I would like you to remember the AO classification of the distal femoral fractures. And you can recognize that in type A, the situation is disconnected from the shaft of the femur. The same in type C, but in type B, actually, the medullary nailing is not suitable simply because the fractured fragment is not disconnected from the main shaft. The same or contraindication is present in type 3C, simply because the entry point here has been affected by the fracture, and this makes intramedullary nailing impossible. So it's indicated in extra-articular fractures, something like 3-2 and 3-3, especially in the simple intra-articular fractures like C1 and C2. Again, it is suitable for segmental fractures. Of course, you have here a small fragment distally, so retrograde nailing may work nicely in this situation. Also in knee periprosthetic fractures. Now, antegrade nailing may be suitable for such distal fracture of the shaft of the femur, but I remind you that you need to have at least 7 to 10 centimeters in the distal fragment. Why? Because actually you need enough hold in the distal fragment. You need to pass your nail inside, down, as close as possible to the knee, maybe 1 centimeter distant from the distal part of the knee, as well as having a space to install these two bolts or locking screws distally. Nevertheless, having all this construct is not enough, because still we may be having a chance for the distal fragment to move, simply because of the discrepancy between the diameter of the nail and the diameter of the medulla. And consequently, you may need to have such a bollard screw, 1 or 2, such just to support your nail and centralize it in position. And of course, this will add to the morbidity of this operation. So when you have an extra-articular fracture, supracondylar fracture of the shaft of the femur, extra-articular, you may use the retrograde technique. And it looks simpler, because all what you need to do is to do closed reduction of the fracture by traction and some manipulations. See it in the image. Use flexion position of the knee to augment your reduction, and then install your guide wire and the instruments, and then seat your nail from the retrograde manner, and then fix it by these locking screws, and you are going to get rather reasonable construct. Also, when we get the articular fracture, type C, you need actually, before thinking about the connection to the shaft of the femur, to reconnect and to refix the condylar fracture. And you can do this simply by open reduction, articular reduction, anatomical reduction, and then fixation by 2 compression screws. Of course, when you are doing this, you are going to reconstruct the articular segment, preparing it for connection to the whole shaft, which can be done by installing your retrograde nailing from the knee up. Of course, this needs pre-planning and strategic way of thinking. So you can put your articular screws away from the passage of your intramedullary nail. Now, this has been studied by Gandour, et al., and he described 23 cases with an average age of 63. The fractures were different types of type of the 3-3 fractures, and the fixation was always done by connecting screws and intramedullary nails, and actually the result was encouraging because he got nice healing in 87% of the cases. Nevertheless, some failures, like 4.3%, has happened in the distal screws. Now, another study was done by Hodline, just trying to watch the operative findings in these cases, comparing the types A and C, and actually there was a remarkable blood loss in the type C. Of course, this is logic. The operative time was slightly more, and this is also logic because you have additional steps to fix the condylar fractures. Nevertheless, the healing was more or less equal in both sides. Now, periprosthetic fracture is another indication. And in periprosthetic fracture, we need actually to have a good anatomical reduction. Again, these cases are commonly osteoporotic. So you need to have a sort of retrograde nail, of course, so you can get a good hold of the distal fragment. And the nail has to be placed after thorough and good anatomical reduction of the fracture. Otherwise, you will get disturbance in the knee prosthesis later on. And of course, the nail has to be long enough to have a good hold in the shaft, to support it properly, and to work against the osteoporotic factor here. Now, this has been studied, and the outcome was quite encouraging because in 10 cases of supracondylar fractures of the shaft of the femur fixed this way, in over 2 years follow-up, there was nothing in the knee joint. The knee joint was all right. And actually, the fracture has healed in 3 months' time. And so in conclusion, we can say that this is a good and suitable method of treatment. Also, in cadaveric study, this has been done, but in comparison with the LIS, and it was quite all right because the nail was less morbid than the plate. Now, some other comparative studies has been done to compare the nailing with the lateral plate, which you are all familiar with. And this is a very famous study done by Meyer, in which comparison between the stiffness against axial force and the stability against rotational force has shown up. And here you can see that there is a more remarkable axial fixation in plating, but they are not exceeding that much of the nail. This is in axial forces resistance. Now, in rotational forces, the plate, no doubt, was more stronger. It's more resistant to rotational forces. So, in conclusion of this, we can say that the axial stiffness in the intramedullary nail is maybe as good as the plate, but rotationally, the plate is superior. On clinical grounds, we could not find some sort of quite a good difference between the medullary nail and the plate, because in 45 cases of type 3-3A and C, the retrograde nail was as effective as plate osteosynthesis. And in another 48 cases, there was a low complication rate. Now, some advantages and disadvantages has to be discussed. And actually, the nail has got some remarkable advantages. It is a load-sharing device, and you can observe this amount of callus which is formed here, reasonably good to heal the fracture. It is friendly to soft tissues. You don't do too much dissections. And you can get a good fixation of the distal fragment. However, it has the disadvantages of working through the knee with some rate of knee sepsis and some insult of the joint, which may be shown up later on, something like stiffness of the joint, later on arthritis, and maybe some effect of the presence of the tip of the nail. Now, the complications are non-union in 5%, malunion in 5%, infection in 1%, and the knee range of motion is less, not exceeding 100 degrees. And this was collected from some that some papers presented this. Now, malunion and non-union occurs because of the failure of the construct, commonly in the distal part. And you can observe here that the two condyles has gone apart and the situation is not stable. Also, a fracture occurs in due time at the tip of the nail due to the differential stresses on an osteoporotic bone, probably added to this the presence of the locking screw. That's why I think the presence of the distal locking by the spiral plate and another screw may sort it out. And this was going to give a good distal fixation and a good distal construct. Probably this is going to control the side-to-side movement, preventing the problem of malunion and also maybe the problem of non-union later on. So in summary, I would rather say that the medullary nail is indicated in type 3-3A and the interarticular types of 1 and 2. Also in segmental and periprosthetic fracture, it was very successful. It is less invasive and it is biologically friendly. It is a load-sharing implant, and this is a very good advantage of this. It's not bearing, it's sharing. And the last point is that it works nicely in segmental and in periprosthetic fractures. Thank you very much.